I think there's going to be some people that are going to say, wait, the Beighton score? Like, I hate the Beighton score. The Beighton score has been shown time and time again to not really correlate with function, and we know that over time it goes down. Welcome back to Bendy Bodies with the Hypermobility MD. I'm your host, Dr. Linda Bluestein, and today I'm joined by my guest co-host, Dr. Ina Stevens, Associate Director of the UVA Health EDS and Hypermobility Disorder Center. We are so proud to partner with the UVA Health EDS Center to bring you conversations that connect cutting-edge science with practical, compassionate care for our community. Today, we're joined by two incredible guests from the Brain Inflammation Collaborative. Christy Jagdfeld is a CPA, longtime patient advocate, and caregiver who has spent more than 15 years leading nonprofit organizations, advancing patient education, fundraising, and research initiatives. She co-founded the Brain Inflammation Collaborative to help drive a more coordinated, collaborative approach to infection and inflammation-related chronic illnesses. We're also joined by Dr. Megan Fitzgerald, a neuroscientist whose career has spanned developmental neuroscience, neural stem cells, and regenerative medicine. After developing long COVID, she redirected her research towards understanding the biology of post-viral illness, bringing together her scientific expertise and lived experience. Her work with the Patient-Led Research Collaborative and now the Brain Inflammation Collaborative focuses on bridging the gap between patients, clinicians, and scientists to better understand how inflammation affects the brain and nervous system. You'll notice later on in the conversation, I had an internet problem and I had to leave, unfortunately. But Dr. Stevens jumped in for me and finished out the episode beautifully. This is a fantastic conversation about brain inflammation, neuroscience interactions, and why collaboration across disciplines may be the key to moving the field forward. This podcast is for education only and is not a substitute for personalized medical advice. Stay to the end for a hypermobility hack. Here we go. Well, I am so excited to be here today with guest co-host Ina Stevens, with Christy Jagdfeld, and Dr. Megan Fitzgerald. Thank you all so much for joining me today.
Thank you for having us.
Thank you for having us.
Great to be here today.
Good. Well, I'm so excited for this conversation. I think so many people are going to go, brain inflammation? What? What is this? And hopefully by the end of this conversation, they're going to have a much better understanding of what we're talking about and why the Brain Inflammation Collaborative is such an important organization. So Christy, let's start with you. What led you to create this organization?
Yeah, my daughter was diagnosed with POTS in 2010, and it took us about 2 years before we were kind of get some idea of what was going on. And I joined Dysautonomy International as a volunteer. And as we got going, we kept learning more and more about what was going on. And she ended up having EDS and mast cell and PANDAS. And so at that time, it was difficult to tell which symptom was kind of attached to which diagnosis. I ended up becoming treasurer of Dysautonomy International, but wanted to do more and ended up going to PANDAS Network for a while as a treasurer. And one of the things that stood out is that a lot of the advocacy groups weren't really working together the way that I thought that they could. And I wanted to have a place where research could take place while helping patients at the same time. So I met another co-founder through PANDAS Network because I don't have a science background. So I needed someone that could handle that piece of it. And I threw the idea out to her, and we got started in 2022. And it's been really quite the journey. Really, there's been a lot of different things that pediatrics being one that we really wanted to include. So it took us a little bit longer to get started, but that's the gist of why the organization was founded.
And for those that are not familiar, can you just briefly tell us what PANDAS is?
Yeah, PANDAS is a neuropsychiatric disorder that happens after a strep infection. Typically, it's children, but you can get it as an adult. And it's often a stronger strain of strep, or, they're not really sure why some people react this way, but you have a lot of behavior changes, OCD being really a big one. those were some of the things that didn't match up with the POTS and EDS diagnosis. And so, we had further questions, and that's when the PANDAS diagnosis came into place.
That's definitely something that has come up a little bit from time to time. I think we need to do a full episode on this at some point, PANS and PANDAS. Okay, so Dr. Fitzgerald, how did your scientific and personal experience shape this work?
Yeah, I'm happy to speak about that. So I'm a translational neuroscientist. I'm the scientific director at the Brain Inflammation Collaborative. And I came to EDS research relatively recently. My training was in neuroscience and neurology. I was doing work in regenerative medicine and neuropsychiatric disease in a hospital-affiliated lab when I became sick with COVID in March of 2020. And like so many of us who were sick then, I developed long COVID. I was fairly severe. And I became involved in the infection-associated chronic condition space with it originally the Patient-Led Research Collaborative, and then I joined the Brain Inflammation Collaborative about 2 years ago, very inspired by Christy's passion to include pediatrics in our research. I can say as well, my interest in EDS as well as long COVID is not purely academic. I am hypermobile, and before I joined this community unwillingly, like so many of us, I didn't know that this was something that could be associated with these sorts of complex chronic conditions. It had been evaluated by clinicians. I'm obviously hypermobile, and it was termed benign hypermobility, and I was very athletic, so it was never a concern for anyone. Together with Christy, we're really interested in studying the overlap between all of these chronic conditions. I think, speaking a little bit more about the science, the Brain Inflammation Collaborative runs a platform called Unhide, which is a digital health platform that brings patients, clinicians, researchers together to capture real-world data for more than 30 conditions that we believe share at least some overlapping biological mechanisms. EDS is one of these conditions, and some of the data that we're seeing that hopefully we'll get to speak to is really striking.
I actually had a good chance to look at this, your whole website, and I found it really fascinating, and I took a lot of deep dives into it. And so I just feel that one thing is really important just for our audience that's listening is if you could, and Megan or Christy, whoever would like to answer this, if you could really explain to our listeners, what do you mean by brain inflammation? Are you using this as, kind of an overall term? Is it neuroinflammation? Maybe distinguishing it a little bit from other known causes of neuroinflammation like encephalitis or even, brain edema that can happen, post-traumatic, and just kind of getting into a little bit of the science of what you mean by brain inflammation, including potentially imaging studies or biomarkers. I know that's a big open-ended question, so go ahead, go for it.
Yeah, I can get started on this. And I know I'm aware that when clinicians hear brain inflammation, those are the conditions that they think of, edema, overt signs that you can see on MRIs or other imaging modalities. We're talking about something that is a little bit more subtle. And this is something that I had seen in my work, since the beginning of my career. Things like microglial activation that you can't see using MRI or any large imaging modality like CT scans, anything like that. So it can be difficult to assess this in living patients, even though we are developing or we're learning more about some signs that can be accessed, peripheral blood and things like that. So we're talking about microglial inflammation, we're talking about mast cell infiltration and mast cell activation, and because that affects not just the periphery and symptoms that a lot of us experience there, but also there are mast cells that are in the brain that can become activated as well. So these are kind of the more subtle signs of that we are talking about when we're saying brain inflammation colloquially or neuroinflammation.
Yeah, and that's something that when we picked the name for the organization, it was really difficult. We went back and forth between inflammation because that's what researchers and clinicians probably prefer, and patients maybe more so the brain inflammation piece of it. So yeah, it was a discussion that we had and didn't take lightly, but we landed on brain inflammation.
Well, I have a kind of follow-up question to this, if that's okay. One thing that, in terms of what I know about brain inflammation and looking into it as an infectious disease specialist, a lot of the literature is on animal models, on mouse models, autopsy specimens, even of humans, patients with, post-infectious phenomenon such as long COVID. But the living human being, there's very little data. That's difficult to do. I mean, we can't really cut open somebody's brain or get a little biopsy just to get some data. And that's not quite ethical. So I'm really interested to know if you all have been looking into different biomarkers, potentially that has already been identified in the mouse model, or that has been seen in some of the autopsy specimens looking at different biomarkers. And what do you think is potentially available to be used or interesting, in terms of developing further research? And can you talk a little bit about that?
Yeah, I think one of the most interesting advancements in terms of, as you're saying, Dr. Stevens, it's impossible to study this in living patients. I had done a considerable amount of work in mouse models as well as in autopsy cohorts for that exact reason, because you had to, use tissue. You couldn't see this using any imaging modalities. But some of the newer MRIs that are going up to 7 Tesla MRI are able to pick up things that we were not able to see just 5-10 years ago. So I'm really encouraged about some of those developments because that gets right at, what is happening in the central nervous system. And I know that there are a couple of studies that are being undertaken on POTS and EDS, where that specifically is being answered. Or being asked, I should say. Hopefully it will provide some answers. But those studies are, they're trying to get funding for them and they're writing grants and they're underway right now. I think in terms of blood biomarkers, that's tricky. I think that there are a number that are also in development. And as far as I've seen, I haven't seen data that is super convincing in terms of what is going on in the brain and measuring it in the periphery. But that's not to say that it's not happening right now. And certainly a lot of these immune markers and general inflammation markers that we have in terms of cytokines that have been explored, they do correlate with these conditions, but it's not diagnostic, so you can look and you can say, okay, these people have they have peripheral markers of inflammation. They have these symptoms that would be that mean that they probably have central inflammation like fatigue, brain fog, things like that. And then, like you're saying, on autopsy studies, these things are typically confirmed, right? It's just difficult to do in living patients. And this isn't just for, our world. This is, the TBI world is affected by this as well. There's a lot of neurological conditions that can only be really accurately diagnosed post-mortem, unfortunately. So it's not a struggle that just our communities face. It's something that anyone with a brain-related disorder is dealing with. So it's one of the most, a place that we hope to see a lot of progress over the next 10 years or so. And I think there's a lot of researchers now who are tuned into how neuroinflammation can impact the conditions that we're living with, these complex chronic conditions ranging from autoimmune disease to EDS. And I think that's one of the most encouraging developments that I've seen over the last 5 years is that, it was a lot of these symptoms that we experienced were psychologized. And now there is widespread acknowledgement that these are really being driven by the same inflammation that's causing the symptoms that we're experiencing in our bodies.
That's the key message right there. You just hit the nail on the head. I mean,
That's really why the brain inflammation was created, trying to get at, I have several family members that have chronic illness, and the mental health pieces that were obvious were going along with the PANDAS or even psoriatic arthritis. You have this autoimmune response that creates inflammation. You may be having anxiety, depression, panic attacks, and it's not because you're worried that you're sick. That's not it at all.
And I think one of the most interesting developments, and again, this is preclinical, but there's some studies of endosomes in the blood that are coming from CNS, central nervous system inflammation. And so that's an area that I have a PubMed alert set up for myself, and people might be interested in looking into some of that. But it is preclinical at this stage. It's not something that can be done in the doctor's office yet.
Can you explain what you mean by endosomes?
Yeah, so these are little packages of materials that, on a cellular basis, when I say little, I mean microscopic, like subcellular, smaller than a cell. So very, very, very little. I'm trained as a microscopist, so just to frame that, very, very microscopic packages of materials that can be released from the cell, or it can be used for cell-cell communication. But what some researchers are trying to do is trying to see if these packages that are released from cells, if they can be detected in the blood and in neuropathological states, are there differences in patients with these conditions versus controls? And can these be detected in the periphery? So you're trying to detect things that are there at very, very low levels. And that's one of the technical challenges there, as well as the scientific challenge of figuring out exactly what this is going to be and what this might look like from one condition to the next and one patient to the next.
And I thought it was so interesting what you were saying about the microglial activation and the role that that plays with the brain inflammation, because that also could explain why something like low-dose naltrexone is effective for so many people that are suffering from these conditions, because that does help with the microglial activation.
Yeah, and in the pet world, again, in imaging, which is, very promising, they are developing some new ligands. Ligands are things that bind to cells. So in pet, which I don't know if any listeners have gone in for a PET CT or a PET test, they will inject you with something that's radioactive, and whatever it binds to shows up. It's like on a camera image, it's detected. So what's really cool with the microglial inflammation is that they're developing some new PET ligands. That's what they call the compound that they would inject. It has a radioactive component to it that they can detect with their PET cameras, but these ones specifically combine to activated microglia. So I've seen some of the results for some of the original trials for these, particularly in long COVID, and it does look promising. It's not in widespread use yet, but I think it's really interesting because, again, 5-10 years ago, I was looking at postmortem studies and we were counting little processes that the microglia were shooting out to determine whether they were activated or not. And you can absolutely see it under a microscope. There's no way you're ever going to get that level of resolution in a living patient.
And you're seeing this both in human data and as well as in animal data?
Yeah, the human studies, for long COVID, the microglial inflammation, yeah. And just overall systemic inflammation as well.
Right. I think there's some really interesting data that's looking at, the defects with just like neurotransmitter, just transmission across the microglial cells, across the neurons. And a lot of that is right now still very much an animal model, but I think and in postmortem, I think we need the human data. I mean, that's where we're going to be able to really say this is exactly what's going on and get to some kind of directed treatment. I mean, that's obviously the goal. Are you involved, Megan and/or Christy, involved in any of trials, ongoing randomized controlled trials, looking at human data at some of these imaging studies or looking at the biomarkers? And love to hear about that.
What we're looking at actually is patient-reported symptom data at the Brain Inflammation Collaborative. I do other work with, for example, the NIH's Recover Initiative, but the remit of Brain Inflammation Collaborative's work is to really look for patterns in real-world data in patient-reported symptoms. We are trying to facilitate some biospecimen collection studies with different collaborators, but what we're set up to do on our own in the Brain Inflammation Collaborative is to handle this side of things where we're tracking how patients are doing in real time. So what other researchers can do is see, do their biospecimens, do they change over time? And we're handling the symptom tracking and the validated surveys. But I don't want to also minimize the data that we can glean from patient-reported data as well. There's a tremendous amount of information there, and we're able to do this at a scale that wasn't available until recently. So we have thousands of patients in the platform, and we're seeing some really interesting patterns in this data already that is just coming from self-reported data.
Well, one of the things that we found important is not only to connect the patients to the researchers, and maybe we can do customized questionnaires and researchers can ask specific questions, but giving back to the patients too, where they can track their symptoms and kind of coordinate all of their health journey in one place. So you may have the symptoms you're tracking for the day, but you have some notes, you had something that happened to you that day. You had surgery, you had an injury, you had a virus, something like that. You can make a note and you can track your treatments and your interventions. And then when you go to see your clinician, you can print a report and it shows the month, what happened, what did your symptoms do with your different treatments, with your surgery afterwards, all of those things. They can connect their electronic health records so that they can see all their lab reports in one place. And Megan, I think you mentioned the validated survey assessments. That's how we get a lot of the questions that are asked within the platforms. And Megan, you could talk a little bit about what the validated assessments are, but patients are able to get a score that goes along with these assessments, and they can track their scores over time. So if they have a clinician that uses some of these scoring systems or is interested in it, they can talk to them about it and say, this is what my score has done over the last year, whatever that looks like for them.
Yeah, two scoring instruments that we have that I think might be interesting, particularly to this community and this audience. We have the Beighton, which is a measure of hypermobility in the platform. So participants can take this remotely and they can report their scores, and we can track this longitudinally over time. Longitudinal data is so important because then we can see how people are doing, not only at, brief momentary assessments, but as their conditions progress and as time goes on. And before these sort of digital health platforms were around, this would have relied on return visits and follow-up appointments, which are expensive and burdensome to the community. Now people can do this remotely from the comfort of their own time, of their own home, at their own time and convenience. And I think that the return on investment that we're getting is tremendous here. So I mentioned the Beighton. Another one that we have is the short form 36, which is a well-validated quality of life instruments used across many disease areas. And so we can compare people with, for example, EDS to the general US population. Now, people who enroll in Unhide, it's open to anybody. It controls healthy people can use it as well. And it's a great way to support a loved one who may have a chronic condition. But many people in our platform have conditions like ME/CFS, long COVID, EDS, autoimmune diseases. So a lot of complex chronic conditions. Now, the people who have EDS in our platform, as compared to the general US population, their physical functioning, energy, pain, and general health scores are less than half of American population norms across the board. So that's not a subtle difference. This is kind of numbers that you see in really, severe diseases. And I think that it's important to emphasize that this is real world data from people living with EDS today. It's not just a select trial population or a highly selected research cohort. And so it represents what EDS looks like when overlaid with these other chronic comorbidities in the community. And I think the energy and the fatigue scores were really striking to me. The average score was about 11 out of 100 for people who had EDS compared to a population norm of around 61. And that's really profound. It maps onto what we know about the overlap with ME/CFS and dysautonomia, just showing how these are not separate problems. They're kind of part of the same picture. And I think that's really the power of the platform that we're developing. We can see, quality of life isn't just about one symptom set. It's about kind of the cumulative burden of managing multiple complex conditions simultaneously. And many of these conditions are still poorly understood and underdiagnosed.
So I want to point out really quickly, because I can usually anticipate the questions. I think there's going to be some people that are going to say, wait, the Beighton score? Like, I hate the Beighton score. So I just want to point out that the SF-36, that's a great tool. The Beighton score has been shown time and time again to not really correlate with function. And we know that over time it goes down and you can have injuries and surgeries and things like that. So it's good that you're asking for that and having people do that. But I just think some people are going to say, wait a minute, that doesn't really correlate with how I'm feeling.
We have seen that in some of our patient comments as well. And we do allow for like a self-reported Beighton scale, so that they can, if there are aspects of it that they cannot do, like, bend over and touch the floor, that can be eliminated and not calculated into their score. But I've seen this in the data and the first, preliminary analysis. And like I said, I am relatively new to EDS. And I was like, okay, so this is what the patients were talking about when I saw this data set. And I think it's powerful because it's in there, but it also shows we need to develop a better tool. Like that is part of what we're seeing in the data. It's not, the Beighton is not correlating as well as I would have thought with measures like the SF-36, with the fatigue severity scale and these other validated tools that we have in there, nor is it correlating with, how patients are feeling, right? So we have that in there. We can track it longitudinally over time as well, which, like you're saying, was going to be really interesting to see, because flexibility changes even in a normal population that's healthy. But, if people are, I think that we can actually kind of prove that this is maybe not the best measure for people who are really severely impacted. It might be picking up people in the beginning of their illness trajectory, but then after they've been sick for a while, people can no longer perform some of the tests. And then some other, there's just a lot that's happening in people's bodies that can make that less and less reliable over time. So I think we are seeing that in the data as well.
Well, and I think that that's important to note that we've talked a little bit about maybe this is a place where we can help. We can improve the scoring and maybe come up with a better scoring instrument.
Yeah, for generalized joint hypermobility, right? It's not a scoring tool for EDS. It's for generalized joint hypermobility. And speaking of EDS, so do we think that we do you all think that these are separate diseases? That Dr. Fitzgerald, you kind of started to comment on this a little bit. So do you think that hypermobile EDS, HSD, POTS, MCAS, ME/CFS, long COVID, et cetera, are these separate diseases? Do you think that neuroinflammation is something that happens with most people with mast cell activation? How does this fit in with autonomic dysfunction and all of these other things? Do they have shared biologic pathways? What do you think is the story there?
Sorry, that's a lot of questions. I can say for one of them, MCAS, I think is neuroinflammation. I do think that. Are they all the same condition? Or are they separate conditions? I think that's something that our data can tell us, and I'm really interested to look at that, because we do have people who have only a single one of these diagnoses, who don't have the trifecta 4 or 5 diagnoses. So I want to see over time, do they accumulate these diagnoses, or are there people who just stop at one diagnosis? So I don't know the answer to that. I don't know that it is known yet, and this is something that Christy's going to the EDS conference pretty soon, and this is something that I think that our data set can really help to answer, because I don't know the answers to that yet, and I don't know that it is known. Maybe some people, they can arrest the course of a progressive condition, or maybe some people just have the genes for one of these conditions. I don't know yet, but there are certainly people. The patterns in the data with EDS are extremely striking. The one thing I can add to that is we also saw neurodivergent people have higher rates of EDS in our data set, people with ADHD and autism spectrum disorder in particular, which was, for me, it was a little bit of an unanticipated thing that I saw in the data. And then when I started reading about it, I was like, oh no, this actually fits into the literature really well. It's been really interesting. And I do, kind of wondering, is EDS kind of a link, with this connective tissue disorder, or is it, the immune system is causing the connective tissue issues? I think there's a lot that we can look at, both in our data set as well as in the pathobiological studies. But I hope that those studies will be informed by what we're seeing in terms of the diagnosis and the symptoms. A data set, we have over 4,000 participants now, about 4,200 adult participants. So this is a large data set of people with multiple comorbidities. And I think we can look at that pretty closely and hopefully answer some more of those questions. Because I think the only one I feel confident saying right now is I do think MCAS is neuroinflammation, or causes neuroinflammation. Yeah.
I have some questions just about in terms of how you're, kind of gathering the data for the surveys. The first question is the patients that are putting their data in and they're giving you a diagnosis. Is this like they have been diagnosed formally by a physician? They've been diagnosed formally with either, dysautonomia, autonomic dysfunction, mast cell, EDS, long COVID, or are they giving you the symptoms and then it's, well, I think I have this? That's question, one. And then, you're saying you're kind of measuring this over time. So how often are you asking people to put in their survey data? Is it monthly? Is it every couple of months, weeks? And I'm just curious in terms of, just how they're feeling, let's say physically, or is it emotional changes through, or is it just when maybe, as you mentioned previously, they get hit with something like they had another virus, so they put in new data into their survey? What are you expecting from the data collection? Sorry, lots of questions there.
No, it's okay. I think, a lot of this is up to the patients themselves. We aren't policing anybody. We want people to get a good return on investment for the data that they're providing. As Christy had mentioned earlier, we provide patients with the charts of their symptoms so that they can take these to their doctors. We also have score reporting now, so people can see how they are scoring on these validated assessments over time. Each of these validated surveys, we have a different cadence that we tried to think out pretty carefully in terms of what's the minimum amount of data that we really need on the research side versus, what would be too much of a burden for people to put in. So each of these has a slightly different cadence so that people aren't getting slammed with 5 or 10 different surveys to answer at once. Because we have over a dozen surveys in the platform, and they are given at a certain cadence. Some are one time only. And then others are given repeated over time. So some are asked every 3 months, and then others are every 6 months. We have some that are the Beighton is only done annually, for example. So we have different cadences for every survey depending on feedback from the patient community as well as feedback from researchers that we work with. Patients are encouraged to log their symptoms daily, primarily for their benefit, so that if they start a new treatment, they can see how are they responding to that treatment. If they had a triggering event, how have their symptoms responded to that triggering event? And then we do have access to the symptom data as well as on the research side. So we can see how those trajectories are changing over time. But in general, we try to be very cognizant of the patient burden as well. These conditions, as you all know, are very fatiguing. They're difficult to live with, and we don't want to add any more burden. We want to make people's lives easier.
Yeah, survey data collection is definitely, fatigue. Survey fatigue is definitely a real thing. So I was wondering how you manage that. Thank you.
And I can say thank you to anyone who's in the platform who is filling out these dutifully. Please be aware your data is so valuable. We cherish it, and we value you.
Yeah, that's a really good point. We are very thankful for all of the patients that do take the time to fill it out. But, one of the things kind of just answering that question a little bit further is we didn't want anybody to get missed if you weren't diagnosed, because you know how hard it is to get diagnosed. So we wanted people that suspected it. And you can always go back if you get another diagnosis and add that to your list of diagnoses. And, to Megan's point, looking at some of the survey data, we might be able to see, well, it looks like this person has maybe EDS, but they were never diagnosed with it. What does that look like to patients? And, there's so many doctors out there that really just think they're not seeing these patients.
Yeah, that's the ironic thing. Before we go to break, I just want to point out that the spider tool is something that, although you don't need other things necessarily to add, but that might be something to consider in that it has, the different domains. So the, neuromuscular, pain, fatigue, GI, dysautonomia, anxiety, depression, and urogenital. So that would be something that would capture a lot more than like the Beighton score, which is for generalized joint hypermobility. So we're going to take a quick break. And when we come back, I want to really dig into what we actually know for sure, what we suspect, what we still need to prove. And we're going to talk more about brain inflammation with this incredible group after the break. We'll be right back. One of the questions I get most often is, Dr. Bluestein, what products do you actually use and recommend? To make that easier, I've created an Amazon storefront with many of my favorite products for joint hypermobility, EDS, POTS, MCAS, chronic pain, etc. If you're already shopping on Amazon, I would be honored if you would consider starting through my storefront. It does not cost you anything extra, but qualifying purchases help support the mission of Bendy Bodies and allow us to continue creating free educational content for patients, caregivers, and clinicians around the world. Please visit amazon.com/shop/hypermobilitymd to learn more. Thank you so much for helping us continue this important work. Okay, we are back, and I know that Dr. Stevens has some great questions for these brilliant young ladies.
Well, just during the break, we were just talking a little bit about how important it is to really study this. And I feel like there is so much that we need to know, from the basic science to the surveys to clinical data. And, I feel like there's an unlimited amount that we need. But This is just question number one, literally, and you can just answer it as if we had unlimited funding, what type of research would you want to do right now? How would we perform this research? Where do you think the most necessary steps are going next?
I just feel like, I mean, there's really so much there. I really think that the coordinating of the research capabilities, there's so many different projects that have started, and how can we better work together to use the dollars wiser? And so I think that's not really answering your question about the science, but it's making the whole point of we keep having different organizations start different projects, and the money gets thrown in all of these places. How can we collaborate together to make that better? But Megan, I don't know if you have anything specific about research that in your mind comes to the forefront.
I have so many ideas. I'm not exactly sure where to start. I will reiterate, I'd spoken earlier about these enzymes and extracellular vesicles and the EVs, extracellular vesicles, that you can abbreviate them as EVs, that you can actually see in the periphery. It was one of those moments I had earlier this year where I had been hearing about this and I was kind of a little skeptical. I was like, this is too good to be true. And I emailed a couple of colleagues and I was like, can I see some of this raw data? And it was really cool, and I think that they're also looking at, these EVs that can be investigated for intrinsic abilities to stimulate tissue repair. So not only as a, diagnostic or a biomarker, but also as something that we can use to actually help to treat these conditions, right? So I think that's one reason it's such an exciting field that I'd love to see a little bit. I'd love to see considerably more funding go into the immune profiling as well of these conditions. Like, we know that there's so much immune dysregulation that happens in these conditions, and we're at a point where we have drugs that can target specific aspects of immune dysregulation, but we don't know which patients they're going to work for, right? So we need to figure that out as well. And I think the first step is figuring out, what manner of immune dysregulation does a patient who's presenting with heterogeneous complex conditions, what are they best going to benefit from, right? So to me, those are the two things that I would put money into right now, something to fix and diagnose, as well as something to, use some of the cures that we have right now, or potential cures that we have right now, and treatments that we have right now for these complex chronic conditions. Just at the top of my head. I'm sure I'll think of many more things tonight that I would love to see if there was infinite many.
No, great. I very much agree with both of you that, the more heads together and the more that we can all put together, just, in terms of like, this is our source of funding and let's just all put our heads together and get one great study going. And it really needs to be very much, we need to get to the basic science of this to figure out, as we say in infectious disease, we need to know the bug and the drug, but we need to know the biomarker and who is going to respond to what appropriate therapy. And, taking care of these patients can be sometimes, and I know Dr. Bluestein, we talk about this a lot. We try this and see if it works, and we try this and we hope it works. And we need to know which patients, and I am so appreciative of this large survey that you're doing. It's kind of being able to categorize those with certain comorbidities and who may fit into what even just kind of phenotype that would possibly, even if we don't have a biomarker yet, potentially phenotype may respond to a certain therapy or intervention.
Well, and I think the pediatric piece is important to put money there. There is very little pediatric research. It's difficult to, you have a lot of regulations around the pediatric piece. And that was part of why our platform took a little bit longer to launch that piece of it. But I think what's happening with these kids, my daughter's a good example. As a baby, she had different things, and as a toddler, and our doctor explained everything away, whether it was she was more aware of her body, she was having autonomic issues, and growing pains, small stomach, you name it, it was always explained away. But what are these things that could help people become educated about the chronic illness space, so that when there is an infection or things do escalate, you aren't kind of blindsided with what is this, what's next, and all of your pediatricians and not regular doctors just have no idea how to help you. So I think if we can get some education around what does it look like before some of these diagnoses happen, there are signs, and most patients that I talk to will tell you that.
I am so glad that you brought up the pediatric piece because that was my next question for you is I am really interested in the research, obviously being a pediatrician, but the challenge is that these children are developing these issues during key developmental times, not only just physical, but their brain is developing. And, could this potential infection or this particular disease entity, what could be causing, that change in their development, in their neurodevelopment over the course of their lifetime, and how is that going to manifest as an adult? I think it's very unpredictable, and we need to be able to help these kids. I take care of a lot of these children, and they're missing huge pieces of their lives because they're not able to participate because they're so ill.
Yeah, we have a teen group that we just started, and somewhat to kind of test some of our surveys and give feedback on it, but also how do we reach teens, how to recruit, how do we message them? And I think that it's so isolating as a teen to have this happen. So, you know, being able to speak to other teens that are in similar places.
Yeah, I couldn't agree more with both sides. It's for me as an adult, I got long COVID and it was months off of work. It was awful. It was awful for me and my family, particularly because I was the primary caregiver of my son who was a toddler at the time. But at the same time, one of the things that was in my head is, what if this happened to me when I was in high school, right? Like I was an athlete. I would no longer be able to play sports. I would you know, miss college application deadlines. I would miss exams. Like all of these things that we have across childhood and adolescence, they're so kind of regimented in terms of timelines. You miss out on events with your friends that it's just such a different time of your life socially. And so I think the impact on kids and their families is just tremendous. And then you have a whole lifespan ahead of you where it's kind of this question mark, like, am I going to be able to, work productively? Am I going to be able to handle a full college curriculum or med school or, some of these massive decisions that you have to make in your early life? And most kids who are blessed with good health don't even have to think about this. It's just a matter of willpower to get through and, good discipline. But, for kids with chronic conditions and diseases, it's just heartbreaking that they have to think about this and they might be judged more harshly by their peers who don't really understand what's going on. And even some of the adults in their lives and their school systems who really don't understand what these kids are going through. And that's from like the social side, right? So it's, the empathy as a mom, as someone who's grown up
But that's
that I
so
had. But then,
important.
yeah,
So
but then even
important.
from what you're saying, the critical developmental periods, like I don't know if the audience is aware, if pregnant women get an infection, it can lead to, during certain trimesters of pregnancy, it can lead to long-term developmental consequences. And these same things can happen, throughout postnatal life and postnatal development too, because the brain is developing and it's changing in this very, kind of amazingly regimented way for all of us, of neurodevelopment that happens throughout postnatal life into our early 20s. And so what happens when, there's this massive inflammatory event, maybe it's an infection, it is triggered or an autoimmune disease at onset, right? What happens if longitudinally, and that's really been understudied, just across the world, it's just been completely understudied. And in the studies that we do have, they're observational. There was a war at this time. There was a famine. Let's see what happened, 40 years later to kids who had to grow up like that. And we're going to, unfortunately, go through a great cultural experiment with COVID as well, seeing what happened to people who were infected. And one of the reasons the Recover Initiative that's tracking them is so important. But I think, the Brain Inflammation Collaborative, we're looking with a much wider lens on associated conditions so we can really start understanding the impact of these critical periods of development, both the social side as well as the neurodevelopmental side. And, intellectually, this is something I've spent kind of my career on intellectually, but then also, just being a patient now, just having that insight that oh my goodness, like, what these families are going through is just tremendous. It really is. And just any kids who are going through this, like, my hat's off to you for, the bravery that these kids are showing, and just like getting through the day and the resilience that they're showing. It's tremendous.
Well, Megan, I have to say I am so appreciative that you have just brought up all these points, because this is literally what I am seeing every day in taking care of these kids. And these are questions that I'm being asked as a pediatrician, as an infectious disease specialist. What is going to be for my child in the future? Is there anything to potentially prevent this from happening? Is there any research going on that's like preventative strategies for these children that may be hit with a kind of a long COVID or post-infectious phenomenon, and they're obviously struggling tremendously? I mean, there's data now that is showing that children after a COVID infection are actually at higher risk to develop long COVID than adults are, and that about 6 million children are currently living around the world with long COVID. That's a huge piece of the population. We have to help them through this outcome. We got to help them neurodevelopmentally. And then the other piece that I don't know if we're looking at this, but I am very interested to know if you're getting some of this in your survey data, are the children who developed a huge inflammatory response just to COVID-19, like what we called MISC, which is, the multisystem inflammatory, basically devastating symptoms that happen after COVID-19. It's very much like a tremendous inflammatory response. And even after they've recovered and don't develop long COVID, what kind of problem that may have caused just from that tremendous inflammatory response just to this virus? Are you looking at children in this tremendous survey study that you're doing? How many of these patients are children? And are you looking at anything differently? I guess that's also a question.
Yeah. So we have, we only built the pediatric platform. It's less than a year ago that we launched it. I'm sure, if you're conducting pediatric research, it is complicated both from an ethical point of view, because you have to get the parents on board, as well as the child on board. And then you have to make sure that you're tailoring materials appropriately for each age group, right? So you've got the 13 to 18-year-olds, you've got the 7 to 12-year-olds, and then the 2 to 6-year-olds. And we aren't looking at infancy in our study. It's 2 years old and up. But infants are even more challenging because they develop so quickly, right? So those are the different age ranges that we've segmented by in our digital health study. So it was a while to build the platform and to try to tailor it for each of those age groups. And we do have about 100 participants enrolled across 100 pediatric participants enrolled across our different diagnoses. And we are actively trying to recruit more pediatric participants across, the whole pediatric span of life right now. I can't emphasize enough how important it is to be able to understand what's happening. And we do ask questions from the parents, as well as from parents or caregivers, as well as from the participants themselves. I do think that there's some research where they're only looking at one side of that coin, usually the parent-reported symptoms, but we thought it's really important whenever possible to get responses from the participants too. So that it's not just an observer point of view, right? We want to hear from the kids and teenagers themselves in their own words. How are they experiencing these symptoms? And one reason for that is so for, if a patient comes to you, Dr. Stevens, you can be asking the questions in the terminology that is the most resonant with that patient, depending on what stage of life they're on. How do kids describe brain fog, for example? It's one of our surveys in there, because it's a symptom that's very common. It can be really disabling for kids who are trying to focus in school, and trying to fight through this. But brain fog itself is such kind of a term that kind of trivializes it. So, and kids might not even use that term, might not be familiar with it. So we're trying to understand, that's one of our active surveys, is trying to understand how kids talk about neurocognitive impairments that they might be noticing and they might be experiencing. And we worked on that with a researcher at Columbia, Dr. Mara Kubaldina, who's actually a Lyme's disease specialist.
Interesting. That brings up another whole point about, where, a child just describing their symptoms, or even sometimes parental report, or let's say report from teachers, sometimes it's just like, well, we do have to rule out other non-infectious, non-neuroinflammatory, but Does this child have something like Tourette's syndrome? Does this child have something like ADHD? Because it could almost be described in a very similar way. And so I think so importantly, we need to develop further biomarkers, imaging studies that can really show the kind of a true difference between all these different disease and syndrome entities. Because that's, a child comes in with maybe the complaint of brain fog. They don't know how to say that. All they are really being told is by the teacher, they're not paying attention in school. And so, so this child must have ADHD. And maybe that's really not what's going on here. It may be a component, but it may not be the whole story. And so really being able to tease out all these pieces, I think, is where we need evidence-based diagnoses, evidence-based treatments, and evidence-based outcomes. And I think we're on the track for that, but we still have a long ways to go.
Yeah, and I think it's really important that it has been elusive for a very long time. It's been 12 years for my daughter. And I think in the meantime, it's really important to be able to succinctly have the child's description put into a way for clinicians to use that. And to Megan's point of how does a 6-year-old, how does a 10-year-old, how does a 22-year-old describe brain fog, so that, and they're all going to be different, so that a clinician can use that information until we do have these markers and these imaging to do that further. And maybe it's still going to be elusive for another 10 years. I don't know the answer to that, but in the meantime, I think it's important to have these descriptions.
Well, I have to say, I think that with the two of you doing this and this brain collaborative that you have, this platform, this longitudinal symptom kind of data that you're collecting, which I think is huge, and you're telling me up to 4,000 plus patients, we're going to get somewhere. And this is just the beginning. And I'm excited to collaborate with you. I think that we have a lot of work to do, but I think that we have it laid out for us, and that's what's most important. I just don't want patients to give up hope. And I unfortunately, sometimes I hear that, I see that. I want to say to our listeners out there that, people are really energized to try to find solutions. And we know what the patients are dealing with. We know how they're suffering. We know how the families are suffering. And we have to be able to find ways to help.
For sure. And I think that really the research piece of it, we need that data collected. And so this is also empowers people that are just looking for this outlet. And so, please join our platform. And there's a lot of benefits across the board.
Well, I know that Dr. Bluestein, I think, unfortunately, probably her internet probably went on a lag. But I know that we're getting close to our time here, and I want to be appreciative of your time as well today. So I know that Dr. Bluestein always likes to end with a kind of perfect pearl, or that we call a hypermobility hack. So do each of you have a hypermobility hack for our listeners?
Yeah, I can go ahead. A lot of, our community has complex chronic conditions. So they might have EDS alongside something like ME/CFS or long COVID. And with ME/CFS and long COVID, one of the most disabling symptoms is called post-exertional malaise. So you do something, it might not even be exercise. It might be just, getting up out of bed for people who are really severe, or people who are, more moderate, doing a load of laundry, right? Nothing that a healthy person would consider exercise, but it's exertion, and it can trigger flu-like symptoms. So that's, it's terrible. You want to avoid that because that's an increase in inflammation. But at the same time, there are certain exercises that can be really beneficial for hypermobility as well as for POTS. And so what I would say for people who do have these complex comorbidities, to make sure to pace. If you want to try any of these exercises, they can be beneficial for a number of symptoms that people might be experiencing, but pacing is just incredibly important. So what that means is start off very small with a very small movement, just a little bit, 10% of what you hope to achieve eventually. see how it goes. And I do think this is the power of symptom tracking apps like the one that we have, because you can really say, okay, this was my treatment this day. I did a little exercise, and you can see how this looks like in your own health data for a couple of days or even a week afterwards. And then just you can build up from there. But the pacing component is really important whenever you're introducing exercise into ME/CFS or long COVID. But at the same time, I have seen people who do benefit from certain targeted exercises, not graded exercise therapy, not anything like that, but using your own wisdom in your own body to try to track your progress and to try to help manage some comorbidities like EDS and POTS.
I love that. That is a great hack. And it's not just a hack, it's a treatment modality that I talk about every day. So I absolutely love your hack. Thank you, Dr. Fitzgerald. Perfect. How about you, Christy?
Well, mine's not quite as detailed and long, but I did talk to my daughter a little bit about this, and there were two things actually. She had a lot of trouble with temperature regulation, and we had this gel kind of neck and shoulder wrap that you put on. You keep it in the freezer and take it out, and whenever things just seemed really, really hard, she would put that on, and she would get her temperature back, her core temperature back, and things were a little bit easier. The other thing is she is super sensitive to mattresses and sleeping. And if they're too hard or those types of things, she's actually sleeping at someone else's house right now for an internship. And she bought one of those eggshell or memory foam type of things. And it has made all the difference for her. She's extremely sensitive to hard surfaces. So that's probably her favorite thing.
Oh, no, those are great hacks. I mean, there's so many little tools and so many things that my patients have educated me on. It's kind of like, no, this particular brace or this particular, whatever a gadget has helped tremendously, and that's what they need. And I'm going to ask you if you could even send a link to what exactly this product is in the show notes, because I know that Dr. Bluestein has a whole list of like her products, and that you can get them through the show notes and even on the Bendy Bodies Amazon link. So if that can help any of the listeners, that would be great. So we would love that. And the last thing that I know is so important is that I particularly would like this information even more. I have some of it, but how can people find you? How can people get involved? How can they potentially sign up to be part of this survey and part of this research that you're doing? How can they learn more about the Brain Collaborative? So please.
Yeah, to sign up for our research, you can go to unhidenow.org, and there's a sign up button. There's some different information about eligibility and an overview of the study itself. But the easiest thing is to click the sign up, and you will consent. You'll create an account, download our app, and you'll be able to start tracking symptoms immediately. We also have another website called braininflammation.org, and that is our main kind of educational, informational site. We do have this separate unhidenow.org for our science piece of it.
Yeah, we have contact us forms if you ever want to get in touch with us as well.
Great. Well, thank you both so much. We just really appreciate talking to you, and I'm personally really looking forward to working with you in the future.
Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube, and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Thank you for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about these conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, my passion is helping people better understand and navigate symptomatic joint hypermobility. In addition to my clinical and educational work, I offer one-on-one coaching, professional mentorship for healthcare professionals, and expert witness services. If you'd like to learn more, please visit the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at HypermobilityMD. As part of our collaboration with the UVA Health EDS and Hypermobility Disorders Center, we also want to share a few helpful resources. For questions or appointment inquiries, you can contact them at ruvaedscenter@uvahealth.org. That's the letter R, uvaedscenter@uvahealth.org, or call 434-243-8200. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. We love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect my views or opinions. Furthermore, perspectives expressed within Bendy Bodies media, including this podcast, do not reflect the views or opinions held by Human Content, Inc. Although we may share healthcare perspectives on this podcast, no statements made on Bendy Bodies should be considered medical advice. Listening to or watching this podcast does not constitute a doctor-patient relationship. Please always consult a qualified healthcare provider regarding your own care. For information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.